Cerebral palsy and CNS infections. Cerebral palsy. Introduction. Also known as static encephalopathy, non progressive damage to developing brain. So, also known as static encephalopathy, non progressive damage to developing brain. Most common chronic motor disability in childhood. It is the most common chronic motor disability in childhood. Motor disability is abnormality in tone, posture, and movement. Motor disability means abnormality in tone, posture, and movement. Intellectual disability can be present or cannot be present. Manifestation, it evolves over a period of time. Management, it has a multidisciplinary approach. Etiology, trauma during prenatal period, uh, perinatal period, and postnatal period. Most common is prenatal period, that is more than 50%. Brain malformations, maternal factors like toxins and torch infections. Perinatal period, birth asphyxia, trauma to head, intracranial hemorrhage. Postnatal period, infections, for example meningitis, trauma to developing brain. Classification based on motor manifestations. Spastic cerebral palsy. So classification is based on more what is the motor manifestation. First is spastic, second is dyskinetic, chorioathetoid type, third is ataxic, fourth is mixed. Coming to first, spastic type, most common type, characterized by increased tone and hyperreflexia. Increased tone and hyperreflexia. Topographical classification: area of paralysis, biplegia, both legs; hemiplegia, one side of the body; quadriplegia, all four limbs, which is most common in India and most common spastic cerebral palsy. Both lower limbs diplegia is seen in preterm babies. One side of the body is seen in neonates, and birth asphyxia of term babies can lead to quadriplegia. Sequelae of periventricular leukomalacia is diplegia. What is the sequelae of periventricular leukomalacia? Diplegia. Sequelae of neonatal stroke is one side of the body. Parasagittal infarction is quadriplegia. In dyskinetic chorioathetoid cerebral palsy, dyskinesia, abnormal movements of the limbs; asphyxia, increased level of jaundice, damage to basal ganglia, causes kernicterus; chorioathenoid, extrapyramidal movements; ataxic cerebral palsy, malformation in toxic, damage to cerebellum vermis, cerebellar dysfunction symptoms. Cerebellar dysfunction symptoms: ataxic cerebral palsy, malformations and toxic damage to cerebellar vermis, cerebellar dysfunction symptoms. Mixed cerebral palsy, combination of all three. Clinical presentation: global development delay, delay in at least two domains of milestones: gross motor, fine motor, language, social; persistence of neonatal reflexes as brain remains immature; Moro's reflex persists after 6 months; spasticity, scissoring posture, seen in spastic diplegia type of cerebral palsy due to increased tone of adductors in lower limb; toe walking, involuntary; cortical thumb due to increased tone of the thumb. Thumb is in a fist posture, abnormal if present more than 4 months. Cortical thumb due to increased tone of the thumb, it is abnormal if present more than 4 months. Vision abnormalities, hearing abnormalities. Management: investigation of choice, MRI brain to localize the area of damage. Treatment: treat symptomatically with multidisciplinary approach due to irreversible nature. Management: MRI brain to localize area of the damage, treat symptomatically with multidisciplinary approach due to irreversible nature. Seizure, anti-epileptics. Spasticity, muscle relaxant like baclofen, Botox, botulinum toxin A, contractures, tendon release procedure. Dystonia, dyskinesia, trihexyphenidyl levodopa, trihexyphenidyl levodopa. CNS infections. CNS infections, pathogenic or bacterial meningitis. Etiology 0 to 2 months, E. coli. 2 to 24 months, H. influenza, more than streptococci pneumonia. More than 2 years, streptococci pneumonia. Overall, most common cause is streptococcal pneumonia for CS infection. Clinical feature: fever, other like GT, CS, seizures, irritability, signs of increased intracranial pressure, intracranial infant, bulged anterior fontanelle, older child, projectile, uncontrolled vomiting, occipital headache, visual defect, papilledema. Signs of meningeal irritation uncommon in less than 2 years old. Neck stiffness, knuckle rigidity, painful flexion at neck, keeps the neck stiff. Brudinsky sign, flexion of hips and knees in response to neck flexion. 3. Cornick sign, resistance to extension of leg while the hip is flexed. Resistance to extension of leg while the hip is flexed. So they won't let you extend their legs when the hip is flexed. Flex hip and knee, extend the knee, pain in the spine region due to stretching of inflamed meninges. That is called Cornick sign. Investigation: CSF analysis. Lumbar puncture, investigation of choice. Contraindicated in severe signs of increased ICT. Can lead to herniation, death of the child. Lumbar puncture: if there are signs of increased intracranial pressure, then do not do lumbar puncture because it can cause to herniation and can lead to death. Instead, contrast enhanced CT scan shows meningeal enhancement. Contrast enhanced CT scan CECT shows meningeal enhancement. There was a lady who had like a severe headache for many years, and then they decided to do lumbar puncture, and when they were doing lumbar puncture she died on the table itself, and most probably she had increased intracranial tension. Findings: CSF, this happened in a hospital. Findings: CSF parameters and findings. Appearance of CSF: turbid or cloudy. Inflammatory cell: increased abundant neutrophils. Protein: increased sugars. Decrease hypoglycorrhea. Hypoglycorrhea, decreased sugar. Normal CSF: less than 5 lymphocytes per mm cube. Then you do gram staining of that. Culture and sensitivity. PCR, which is more sensitive to detect causative bacteria. Complication: acute. Most common complication is seizure and brain abscess or subdural effusion. Seizure, brain abscess, subdural effusion. Gram stain in culture and sensitivity. PCR is most sensitive to detect causative bacteria. Complication. Most common complication of cerebral palsy. Meningitis is seizures, brain abscess, subdural effusion, long-term chronic, most common sensory neural hearing loss, SNHL, particularly in strep pneumonia associated meningitis. Investigation, Brown evoked response audiometry, BERA. Long-term chronic, most common sensory neural hearing loss. Investigation is by BERA, brain evoked response audiometry. Treatment, antibiotics, third generation cephalosporin, ceftriaxone, cefotaxime. No response in 48 hours, then add vancomycin. So you start with third generation cephalosporin like ceftriaxone, cefotaxime. If there is no response in 48 hours, then add vancomycin. Can change antibiotic post culture and sensitivity results. Duration of treatment 7 to 10 days. Neonate 3 weeks. Steroid along with first dose of IV antibiotics. Drug of choice dexamethasone for 2 days. Goal decreased inflammation, decreased incidence of sensory neural hearing loss. Steroids is along with first dose of IV antibiotics. Drug of choice dexamethasone for 2 days. Goal decrease inflammation and decrease incidence of sensory neural hearing loss if you give steroids. For children you have to treat them for 1 week or so, and for neonates close to 1 month, 3 weeks. TB meningitis, most severe form of TB in children is TB meningitis in children. Pathophysiology, pulmonary focus, hematogenous dissemination, CNS focus develops. It is called rhesus focus. Rhesus focus. When immunity decreases, for example during severe malnutrition or fulminant infection, rupture of rhesus focus, seeding spread in CNS and causes TB meningitis. Clinical features, there is a prodromal phase 1 to 4 weeks. Fever, irritability, vomiting. Fever, irritability, vomiting is pleasant, not conclusive of TB meningitis. If undiagnosed, untreated, then causes meningitis. Features of meningeal irritation, photophobia, seizures. If undiagnosed, untreated, can cause coma, increased mortality. Diagnosis, CT brain. Thick exudates in basal cistern, characteristic feature. Thick exudates in basal cistern, characteristic feature. CSF findings may mimic bacterial meningitis, normal 10 to 15% cases. CSF finding may mimic bacterial meningitis in normal 10 to 15%. CSF could be normal. Cells lymphocyte predominance, there is a lymphocyte predominance. Protein very high, more than 1000 milligram per deciliter protein. Normal 20 to 45 milligram per deciliter. ADA, adenosine deaminase is increased. Adenosine deaminase is increased in TB meningitis CSF testing. Ziehl-Neelsen staining in identifies TB bacilli. TB bacilli can be identified by Ziehl-Neelsen staining. CBNAT, cartridge-based nucleic acid amplification testing. Cartridge-based nucleic acid amplification testing, CBNAT, can be done. Cobweb appearance of CSF. When CSF is left undisturbed in a test tube, then it becomes cobweb type. Treatment, anti-tubercular treatment 9 to 12 months. So you have to give anti-tubercular treatment for 9 to 12 years. First 2 months is intensive phase and rest of the months 7 to 10 months is maintenance phase. First 2 months intensive phase, HRZD regimen. HRZD regimen. H is for isoniazid, R is for rifampicin, Z is for pyrazinamide, and E is for ethambutol. HRZD regimen, H is for isoniazid, R is for rifampicin, Z is for pyrazinamide, and E is for ethambutol. Maintenance phase, depending on the clinical status of the patient, you give HR regimen. HR regimen, H is for isoniazid and R is for rifampicin. Steroids for 6 to 8 weeks, you give IV dexamethasone. Few days, oral steroids. You give oral steroids for a few days, IV dexamethasone for. So steroid total therapy is 6 to 8 weeks, that is close to 4 months, but first initially few days you give IV dexamethasone and then shift to oral steroids. Viral meningoencephalitis. Encephalitis involvement cortical lobe. Signs of involved lobe, for example speech defect, focal seizures. Viral meningoencephalitis. Encephalitis, if it's involving cortical lobe, then you will have defects like speech disorders, focal seizures, etc. Etiology. Most common worldwide is Japanese encephalitis virus. You can also take a vaccine against this virus when you are traveling somewhere endemic. So most common worldwide is which virus? Japanese encephalitis virus. It causes meningitis. Even adults take this vaccines. Most common cause of sporadic encephalitis is herpes simplex virus. Sporadic, slowly spreading meningitis. Encephalitis, which virus? Herpes simplex virus type 1. Herpes simplex virus type 1. Japanese encephalitis, JE vector, you have Culex trite and Neorhynchus. Culex mosquito, Culex trita any ornicus. Seen in rural population associated with rice fields. This mosquito is associated with the rice fields. Host is ticks, amplifier host, birds, age school going children, you will see this. Associated with rural diagnosis, PCR is a specific test. CSF analysis, cell count increased, lymphocytes, sugar is normal, protein is slightly increased. Here they have shown an image of basal ganglia and thalamus. Target area, basal ganglia more than thalamus. It affects basal ganglia more than thalamus. Management is supportive management and prevention is JV vaccine. So herpes simplex encephalitis. Features: fever, focal seizures, focal neurological deficit like aphasia, speech defects, behavioral disturbances, and movement disorders. Investigation: CSF analysis, cell count is increased, lymphocytes, sugar is normal, protein is slightly increased. PCR testing, imaging, target areas is temporal lobe. Herpes simplex encephalitis target area is temporal lobe. Here in the image they have shown temporal lobe involvement. EEG, PLED, periodic lateralizing epileptiform discharges. Characteristic findings: periodic lateralizing epileptiform discharges. Periodic lateralizing epileptiform discharges is a characteristic finding. PLED, it's called EEG, PLED, periodic lateralizing epileptiform discharges, which is a characteristic finding of what? Herpes simplex encephalitis. Treatment: drug of choice is intravascular acyclovir for 14 to 21 days. In other skin infections and otherwhere we give them oral, but here it's meningitis, so you give IV acyclovir for 14 to 21 days. Neurocysticercosis, causative agent Taenia solium. It's called pork tapeworm. Usually affects children in more than 3 years. So neurocysticercosis caused by Taenia solium pork tapeworm usually affects children more than 3 years old. Source is undercooked pork or fecal contamination. In infective egg larva form, infectious form in humans, blood and then brain. Clinical presentation: encephalitis, acute presentation, fever, altered sensorium, seizures, history of recent onset focal and generalized epilepsy, seen if cysts are less in number. History of seizures, history of recent onset focal or generalized epilepsy, seen if cysts are less in number. Investigation: imaging of the brain. Here you can see cyst and scolex. Scolex, it indicates that it is a neurocysticercosis. Single cyst with surrounding edema presents as epilepsy. starry sky appearance, multiple cyst per perilesional edema, starry sky, steroids to reduce inflammation, drug of choice dexamethasone, 48 hours, cysticidal therapy, single cyst albendazole 10 to 14 days, multiple cyst you have to add praziquantel. Is a single cyst you have to add albendazole for 10 to 14 days, multiple cyst you add praziquantel. Anti-epileptic if seizures for 6 months, anti-epileptic if seizures present for more than 6 months, focal epilepsy oxcarbamazepine, and general epilepsy sodium valproate. Anti-epileptics if seizure is present for more than 6 months, then we give anti-epileptics. Focal epilepsy you give oxcarbamazepine, and general epilepsy you give sodium valproate. For focal epilepsy you give oxcarbamazepine. In next video we'll see neuromuscular disorders.